And welcome back, Professor Tabs here again. We're going to continue talking about the hypersensitivities, and we're going to talk about, firstly, type 1 anaphylactic reactions. So I'm going to ask you some questions, and then you are going to answer. So take your time, think about the answer, and let's go. Okay, type 1 anaphylactic reactions. How long does it take for this reaction to occur, usually after the exposure to the antigen? This occurs within minutes. And what are the antigens combining with? What type of antibodies? IG what? What immunoglobulin? This is IgE antibodies. Antigens are combining with IgE antibodies. And the IgE is binding to what and what to cause them to undergo degranulation and release several mediators. Okay, the IgE is binding to mast cells and basophils, causing them to undergo degranulation and release several mediators. So what are those mediators? So we're going to discuss three main ones here, and what I will do is give the definition, and then you will name that mediator. Are you ready? This mediator dilates and increases the permeability of blood vessels. We're talking about swelling and redness. It increases mucus secretion, for example, with a runny nose. And you would have smooth muscle contraction, for example, in the bronchi. So what is this mediator? This is, of course, histamine. Next, let's talk about this next mediator. This contracts the smooth muscle of the respiratory system and increases mucus secretion, for example, in the case of asthma. These are prostaglandins. Next mediator, what causes bronchial spasms in this type 1 anaphylactic reactions? This mediator would be the leukotrienes. So remember that with anaphylactic shock, we have a massive drop in blood pressure, and this can be fatal in minutes. So when thinking about the allergens, the common allergens that are associated with type 1 sensitivity, we should realize that usually these are not harmful to the body, but the body sees them as being harmful. And this is why we have this type 1 hypersensitivity, the anaphylactic reaction. So, for example, proteins, you might have a foreign serum or a vaccine, for example, the pneumovax vaccine. How about plant pollens? You might have ryegrass, ragweed, timothy grass, birch trees. And foods, common foods that cause this reaction could be nuts, seafood, eggs, peas, beans, and milk. And let's talk about the drugs. What type of drugs could cause this type 1 hypersensitivity? Very commonly, we would see this with penicillin, sulfonamides, local anesthetics, and salicylates. So, for example, aspirin, which is an anti-inflammatory. And lastly, insect products. What insect products would you see causing this type of reaction? You'd see this with the bee venom, wasp venom, ant venom, cockroach calyx, and dust mites. And finally, mold spores. And you'd also have animal hair and dander. So remember, these usually wouldn't cause a reaction, but in this case, the body sees them as being harmful. And what is happening with these mast cells and basophils in the allergic response? How does this work basically? Well, the body is encountering the allergen, which is the antigen, and then IgE would bind to the mast cells, for example, and then there would be a degranulation of histamine and other inflammatory agents. So to describe this in a little more detail, what happens is the IgE antibodies produced in response to the antigen coat mast cells and basophils. When an antigen bridges the gap between two adjacent antibody molecules of the same specificity, the cell undergoes degranulation and releases mediators such as histamine and leukotrienes. Okay, and continuing on, what we're doing now is we're basically peeling away the layers of the onion and getting down deeper into the mechanism involved here in this type 1 hypersensitivity. So let's talk a little bit more in detail about it. So remember about IgE that it also activates mast cells. So it's activating mast cells and eosinophils, which can aid in the response to helminths. But they are also the mediators of the allergic response. So I meant to say activating the mast cells and basophils. But remember that IgE is responsible for activation and responding to helminths, and it is also a mediator of the allergic response. So speaking more in detail about that, we should know the type of T helper cells that are responsible for stimulating the phagocyte-independent eosinophil mediated immunity, which is especially effective against these helminthic parasites. So going back to the discussion of cytokines, remember that interleukin-4 is responsible for B cell switching to IgE, and this would be found on the mast cells and CD4 T cells, whereas interleukin-5 is responsible for the activation of eosinophils, again found on CD4 T cells and mast cells. So we should know that the interleukin gets the B cells to produce IgG antibodies and IgE antibodies. So we would have the coating of the IgE antibodies, and of course this is not going to be so good because it's going to produce some difficulty, and eventually there will be some release of some degranulation causing problems. So hopefully we can get back into having more IgG than IgE. But let's talk a little bit more about this in detail. The allergic reaction process is quite simple. We should understand that firstly, the allergen will enter the body near the human mast cells, and this allergen would then come into contact with the body cells, and the B cells would be then alerted and turn into plasma cells, which would release IgE. So we have B cells turning into the effector cells, or the plasma cells, and the plasma cells would then release the IgE antibodies, which would then bind to the mast cells. And then you would find that the histamine is released. This is the secondary response. So that first there is a priming, and then there is a response. So when the allergen is next introduced to the body, the IgE causes the cell to release histamine, which causes the reactions which are familiar to allergies. So let's have a quick quiz here. What is it, what interleukin is it that induces activated B cells to class switch to the IgE isotype? Of course, this is interleukin-4. Interleukin-4 is responsible for B cells switching to IgE. And as another quiz, what activates eosinophils? This is interleukin-5. So remember that allergen-specific IgE secreted by plasma cell coats the mast cells and sensitizes the individual to the allergen. And some of us have a genetic predisposition to develop strong T helper 2 cell responses to the environmental triggers. And here's one more question. Where does IgE bind to on the mast cells? This is in the priming stage. The IgE would be binding to the Fc receptors on the mast cells. Now let's talk it through from the beginning, from the priming to the secondary exposure and the release uh, from the mast cells and basophils. So we have the first exposure to the allergen, and this activates the T helper 2 cells. Then there is a stimulation of the immunoglobulin E class switching in B cells. And what cytokine does this? What interleukin? This is interleukin 4. Then we have production of IgE, and this is from the plasma cells. And then there is the binding of the IgE onto the mast cells. Then with the repeated exposure to the allergen, we have activation of the mast cells and a release of the mediators. Now let's talk about the clinical syndromes and clinical and pathologic manifestations of these immediate hypersensitivity reactions. First, allergic rhinitis or sinusitis, or hay fever. What clinical and pathologic manifestations would you see? We would see increased mucus secretion, inflammation of the upper airways and sinuses. How about for food allergies? What would you see? There would be increased peristalsis due to contraction of the intestinal muscles, of course resulting in diarrhea. How about with bronchial asthma? What would you see clinically? Here we would see bronchial hyperresponsiveness caused by smooth muscle contraction, inflammation and tissue injury caused by late phase reaction. And how about anaphylaxis? So we would see a fall in blood pressure, which is called shock, which is caused by vascular dilation, airway obstruction due to laryngeal edema. This is, of course, in the worst case. We will now quickly discuss localized anaphylaxis and systemic anaphylaxis. Describe localized anaphylaxis. Localized anaphylaxis can be described by the target organ responding to direct contact with that allergen. For example, with the digestive tract, the contact would result in vomiting or cramping or diarrhea. With the skin, you would have skin sensitivity, usually resulting in a reddened, inflamed area and resulting in itching. And airway sensitivity would result in sneezing or rhinitis or wheezing and asthma. How about for systemic anaphylaxis? In this case, there would be systemic vasodilation and smooth muscle contraction, leading to severe bronchial constriction, edema, and shock. It is similar to systemic inflammation. Now we will briefly discuss in more detail systemic anaphylaxis, then we will talk about the treatment for type 1. So let's talk about systemic anaphylaxis. Remember that this is usually the result of the presence of an antigen. So just to summarize, remember that there is an antigen in the bloodstream. It enters the tissues and activates connective tissue mast cells throughout the body. There is IgE-coated mast cells, which then results in a mast cell degranulation and release of the inflammatory mediators, as we discussed earlier. So what happens with the heart and vascular system, the respiratory tract, and the GI tract? So let's just think about each of those systems one by one. First of all, what would we see in the heart and vascular system? We would see increased capillary permeability and entry of fluid into tissues, swelling of tissues including the tongue, loss of blood pressure, reduced oxygen to tissues, irregular heartbeat, and anaphylactic shock, which would include loss of consciousness. How about for the respiratory tract? Here again we would see contraction of smooth muscle and constriction of the throat and airways, difficulty in swallowing, difficulty in breathing, and wheezing. And in the GI tract we would have contraction of smooth muscle, stomach cramps, vomiting, and fluid outflow into gut and diarrhea. Now we will discuss finally the treatment for type 1. Firstly, pharmacotherapy and then immunotherapy. As for pharmacotherapy, let's discuss the drugs. So what type of drugs would you use for treatment for type 1? Non-steroidal anti-inflammatories, antihistamines to block the histamine receptors, steroids such as corticosteroids. You might also use theophylline or epinephrine, which would prolong or increase the cyclic AMP levels in mast cells, which would then inhibit the degranulation. So if you can, try to remember this mechanism of the increasing of the CAMP to inhibit the degranulation. How about the immunotherapy used for type 1? So as for immunotherapy, we're aiming for desensitization or hyposensitization, and also known as allergy shots. So you might get allergy shots in this situation, and there may be repeated injections of an allergen to reduce the IgE on mast cells and to produce IgG. So why would we want to produce more IgG than IgE? And as previously mentioned, this is because we would like to have less priming of the mast cell. And this would happen if you had more IgG. So IgG is good in this situation, and IgE is what we do not want to have, not too much of it in any case. So tune in next time for type 2 antibody mediated hypersensitivity.